Assalamu alaikum warahmatullah. Today we are going to discuss how to approach a case of history taking station 2 in MRCP-PSS exam. We know that station 2 is 20 minutes, 14 minutes with the surrogate, and 1 minute to reflect your ideas and thoughts, and 5 minutes with the examiner for discussion about the case. He will give you 5 minutes before going to the station. These 5 minutes are very important. He will give you the scenario. To read the scenario in these 5 minutes, you have to read the scenario and to concentrate for every word in the scenario, because every word has a meaning. You have to keep the name of the patient and to know the name of the patient, the age, the complaint, and maybe he will give you also some imaging, blood investigations, or the patient on specific treatment. So any investigation in this scenario means something and refers to something. And also imaging, if there is imaging, it means something also. If the patient on treatment, so that the treatment may be triggering or the underlying cause of the patient condition or worsening the patient condition. So every word in the scenario, it has a meaning. Also, he will give you your position, either senior house officer or registrar, so that you have to know what's your position, because you are going to introduce yourself to the patient. You have to write good differential diagnosis, a very good list of differential diagnosis of the complaint before going to the station, the white paper. And you are allowed to take the white paper with you with the patient when you are going inside to the station, while you are with the patient, to make it in front of you. So the differential diagnosis is the core of this case. If you wrote very good differential diagnosis, you can approach the case easily. So now we are going to start our station. What you are going to do, shake hands with the patient, introduce yourself, like I'm Dr. Sadiq, Senior Officer of the Medical Department, or I'm Dr. Sadiq, Registrar of the Medical Department or Outpatient Clinic. Confirm the patient identity. Confirm agenda of meeting and take permission of the patient to start the discussion. Like, I have a letter from your GP that you are complaining of blah blah blah, and then take permission from the patient. Is it alright today to discuss this issue with you? Ask open question for the patient. How much do you know about your condition? Or can you tell me more about your condition? Tell the patient that I'm going to write some notes. It will be confidential, and be sure that I'll be completely with you. This is for the patient welfare. Then start with the analysis of the complaint, avoiding jargons, which are the medical terms. Analysis of any complaint: onset, course, duration, progression, improving factors, worsening factors, associated symptoms. After that, when you finish the analysis of the complaint, you ask about your differential diagnosis. You made a list of 7 or 8 or 9 differential diagnoses, so that you have to ask about your differential diagnosis, every differential diagnosis. We are going to take a sample, a case sample, to apply our skeleton. So that this is the main core of the station 2. If you make good differential diagnosis and if you write good differential diagnosis, then you have to ask about every differential diagnosis you wrote in your white paper. Then start with systemic review of the patient after finishing your differential diagnosis, and most probably in this area of approaching differential diagnosis and asking about the symptoms of differential diagnosis for every disease that you meet as differential diagnosis, most probably you are going to approach your diagnosis here. After that, you have to ask about all the systemic review for the patient. Make your ideas and your station is organized. Okay, so for every differential diagnosis, we are going to talk about general symptoms. You have to ask about general symptoms in the form of any loss of weight, and if there is loss of weight, how much kilograms, and for how long, and what about your appetite. High temperature, any history of fatigue, lumps or bumps. Sadness symptoms, any history of headache, loss of consciousness, visual disturbance, weakness, altered sensation, abnormal gait, shaking of the body. For cardiovascular symptoms, you have to ask about chest pain, racing of heartbeats, shortness of breath, and if shortness of breath is positive, you have to take analysis for every positive data with the patient. For example, if shortness of breath positive, when the shortness of breath started gradually, suddenly, or gradually, increasing, decreasing, or the same, do you notice anything that exacerbate or increase the shortness of breath, like exertion or laying down? Does this shortness of breath awaken you from a sleeping session for fresh air? For example, leg swelling. Chest symptoms or pulmonary symptoms. Any history of cough, phlegm, coughing up blood, noisy chest, runny nose. Gastrointestinal symptoms. Any history of mouth sores, acid brush sensation, heart pain, difficulty with swallowing, tummy pain, altered bowel habits, blood in the stool, yellow discoloration of your eyeballs. Genitourinary symptoms. Any change in your water work, in the amount, in the color, any frozen urine at all. Any burning water work. Musculoskeletal, any joint pain, any skin rash. Sexual history. You can ask about sexual history if needed. We are suspecting some sort of infection, HIV infection, or sexually transmitted diseases. And you have to tell the patient, can I ask some private question if you don't mind, not to hurt the patient. So if the patient has partner or not, and if there is any extramarital relationship. Menstrual history for female patients. What about your periods, the last period? Is it regular or irregular? Amount of the blood coming out, and how many pads of the patient is using if menorrhagia. We are suspecting menorrhagia. And if there is amount of blood, the amount of the blood coming out is uh, more than usual. Hematological symptoms, any bleeding from any body orifice, any bleeding under the skin. This is if needed if you are suspecting anemia, for example, and the patient is bleeding or whatever. Traveling history. It's very important to ask about traveling history if you are suspecting infectious disease or disease acquired from traveling history. So if the patient traveled abroad recently, you have to take details about traveling history, when the patient traveled, and where, and for how long, and where the patient is staying during his traveling, in urban area or rural area, any insect bite there, any swimming in pool there, any endemic disease there, any relationship with local girl there. Okay. Then the medical history. Any medical history of long-standing disease like diabetes mellitus, hypertension, heart disease. Surgical history. Any history of surgical operation, blood transfusion, dental procedures, tattooing, piercing, needle shearing. This is very important question to be asked, especially if you are suspecting a patient has HIV infection or any blood transmitted disease or sexual transmitted disease. Any history of surgical operations, blood transfusions, dental procedures, tattooing, piercing, needle shearing. Family history. Any family history of similar condition or long-standing disease. What about your drug list? Then social, like every case in station 2, 4 or 5, social history is fixed for all. You have to ask about, very important. Social history, we know that 4 questions has to be asked in social history. What do you do for living, the patient job, and how much his symptoms affect your job and usual daily activities. Refer the patient to social worker is usual daily activities and social life is interrupted. And refer the patient to occupational health care worker if his job is affected because of his symptoms. With whom the patient is living and who is supporting the patient at home. What about financial support, smoking and alcohol history. Like that you finish the case approximately. Give summary about positive data you found with the patient. I'm going now to summarize the positive data that we found in your case today that you are complaining of blah blah blah. Then uh, ask him, do you want to add anything else? Then ask about his concerns. Like that you finished the case. Very important to be organized and your thoughts to be organized uh, and to approach the case in a pattern that make it easy to approach and make it easy to diagnose and to get very good differential diagnosis and not to miss something there. Of course, when you ask it about differential diagnosis, uh, don't repeat the questions in the systemic review. When you are going to ask about systemic review, you can tell him, I'm going to ask some questions, maybe not related to your condition or to your symptoms, but it will give us a big value. We are going now to make a case sample, to apply our skeleton and this scheme. Mrs. Noha is 27 years old. She has been complaining of weight gain for the last 2 months for your kind care. You are senior officer of the medical department. You are asked to discuss this issue with Mrs. Noha. Now I have the scenario. Straightforward case as a case of weight gain. So I have 5 minutes before going to the station. I have to write very good differential diagnosis for the case. So I'm going now to write my differential diagnosis. Weight gain. So endocrinal causes hypothyroidism, Cushing and pseudo-Cushing, diabetes mellitus, species type 2, insulinoma, polycystic ovary syndrome, and then systemic causes or causes due to salt and water retention, chronic kidney disease, chronic liver disease, congestive heart failure, nephrotic syndrome, any cause causing hypoalbuminemia. So now I wrote very good differential diagnosis for my case that I'm going to discuss with the patient. Hypothyroidism, Cushing, pseudo-Cushing, diabetes mellitus, insulinoma, polycystic ovary syndrome, chronic liver disease, chronic kidney disease, chronic heart disease, nephrotic syndrome, hypoalbuminemia. Now I'm going inside with my white paper and my differential diagnosis written in the white paper, and I can put my white paper in front of me, not to forget something. Now I'm going to discuss the case with the surrogate. I checked handles. Good morning. I'm Dr. Sadiq, Senior House Officer of the Medical Department. Nice to meet you. I'd like to confirm that you are Mrs. Noha, 27 years old. Mrs. Noha, I have a letter from your GP that you are complaining of weight gain for the last 2 months. Is it right? Is it alright today to discuss this issue? Mrs. Noha, can you tell me more about your symptoms or your condition, please? Okay, I'm going to write some notes and be sure that it will be confidential and I'll be completely with you. When this weight gain started exactly, Mrs. Naha? And is it increasing, decreasing, or the same? Is it coming on and off or all the time with you? What about your appetite? Is it more than before? Where do you put weight in your body? Is it all over the body or in certain areas? How much kilograms did you gain recently? Then I did very good analysis of the complaint. I'm going now to ask about my differential diagnosis. For hypothyroidism, I have to ask about any cold intolerance, any bad mood, dry skin. What about your periods? Any difficulty of combing your hair and getting up from a chair? These are the symptoms of hypothyroidism. Any cold intolerance, any dry skin, bad mood, muscle weakness, difficulty of combing your hair or getting up from a chair. What about your periods? Is it regular? If there, what about the amount of the blood coming out? How many pads you are using per day? I finish hypothyroidism symptoms. Cushing. Okay. Cushing. Do you have any skin abnormality or linear skin rash? Do you have any joint pain or back pain for osteopenia of Cushing? Do you have any abnormal hair growth or acne? Do you have any difficulty of combing your hair and getting up from a chair? But you asked in hypothyroidism, no need to ask again because Cushing is associated with proximal myopathy. Okay. What about your periods? Also, Cushing can have regular periods, but you asked in hypothyroidism, no need to ask again. For diabetes. Do you have any history of diabetes? Did you check your blood glucose level before? Any increased thirsty or increase in water work frequency? Insulinoma. Any history of these spells or low glucose level or loss of consciousness? Polycystic ovary syndrome. Any history of tummy pain or lower flank pain? Okay. Any history of abnormal hair growth? But you asked it before. Cushing, no need to ask again. We know that polycystic ovary syndrome can come in the form of weight gain and acne vulgaris abnormal hair growth and irregular menstrual cycles. So most of the symptoms of ovary syndrome you asked it in Cushing already. No need to repeat it. Chronic liver disease. Do you have any history of liver disease? Any history of tummy pain or yellow discoloration of your eyeballs? Any history of blood transfusion, surgical operations, dental procedures, tattooing, piercing, needle shearing? You are searching for risk factors of infection or hepatitis infection. Chronic kidney disease. History of kidney problem. What about your water work? What about the amount and the color? Is there any frozen urine at all? Nephrotic syndrome. Do you have any history of nephrotic syndrome? There is frozen urine. Any history of frozen urine? You asked it before. No need to ask again. Any history of eye buffness or face buffness or swelling, especially at the morning? Any history of recent infection in the last 2 weeks, an upper respiratory tract infection? Congestive heart failure. Any history of chest pain, racing of heartbeats, short suppressed or leg swelling? Hypoalbuminemia. Any history of what about your diet? Is it rich in proteins or balanced diet? Any loose motions, because hypoalbuminemia can be associated with chronic diarrhea. Like that, you finish your differential diagnosis. And mostly in this differential diagnosis, you are going to approach the diagnosis and differential diagnosis. Maybe you'll find this patient has cold intolerance and bad mood, steroid withdrawal cycle. So most probably she will has thyroid hypothyroidism. Or maybe this patient has weight gain, especially in the trunk and in the face and neck, and she has also abnormal hair growth and linear skin rash, back pain, irregular periods, so this patient has Cushing. Some drugs also can precipitate or can be underlying cause of weight gain, like steroid, and you can ask about steroid for Cushing, pseudo Cushing especially. Do you receive any drugs like steroids? You can name it by name. Steroids or non-steroidal anti-inflammatory drugs or painkillers. Okay. Now you finish your differential diagnosis, all the symptoms for every differential diagnosis. I'm going now to ask you some question, maybe not related to your complaint, but it will give us some value. General symptoms. The patient has weight gain, no need to ask about loss of weight. Any high temperature, fatigue, lumps or bumps, same as symptoms. Any headache, loss of consciousness, visual disturbance, weakness, altered sensation, any abnormal gait, checking of the body, same as symptoms. We asked about any symptoms in congestive heart failure, no need to ask again. Pulmonary symptoms, any cough, any phlegm, any coughing up blood, noisy chest. GIT, any mouth sores, acid brush sensation, heart pain, difficulty with swallowing, tummy pain you asked before, no need to repeat. Any altered bowel habits, any blood in stool, genitourinary, any change in your water work, amount, color, and for the urine we asked before in chronic kidney disease and in nephrotic, no need to ask again. Any joint pain and skin rash we asked before in Cushing, no need to ask again. Sexual history. I see that sexual history here not needed at all because you are not suspecting the patient has weight gain already, so you are not suspecting any sexually transmitted diseases. You can ask only with whom the patient is living and if she has partner. No need to ask about if she has customary relationship because no need here. This is if you are suspecting sexually transmitted disease. Menstrual period, of course, our menstrual cycles, of course, you asked about it before, and for hypothyroidism and in Cushing, no need to ask again. Hematological symptoms, any bleeding from anybody or fist bleeding under the skin, because in ecchymosis, for example, can be associated with Cushing. Traveling history, you can ask it in traveling history here, but I think traveling even not needed here because it will not give you any value for a case of weight gain. Any long-standing disease like diabetes, hypertension, heart disease, surgical, any history of surgical operations. You asked about dental procedure, tattooing, piercing, needle sharing, blood transfusion before, and risk as a risk factors or chronic liver disease or hepatitis. No need to ask again. Family history of similar condition or long-standing disease. What about your drug list? Then to ask about social history. What do you do for a living and how much the symptoms affect your usual daily activities and job? Refer the patient to social worker if it affects her social activities and refer the patient to occupational health care if it is affecting her job. With whom the patient is living and who is supporting the patient at home. What about your financial support? What about smoking and alcohol history? Alcohol intake also can cause pseudo-Cushing and can precipitate in weight gain. Now I'm going to give you a summary about what we discussed today or the positive data in our discussion today that you are Mrs. Noha, 27 years old, complaining of weight gain all over your body for the last 2 months with good appetite, with balanced diet and good appetite. And you have complaining of fatigue and dry skin and cold intolerance and menstrual periods irregularities with a lot of blood coming out. Is it right? Do you want to add anything else? What about your concern? I'm concerned, doctor, what could be the cause of my weight gain? I appreciate your concern, but we have to do for you full examination first. Most probably, you have a disease called hypothyroidism. It is due to deficiency of one of the important hormones secreted from the gland in front of your neck called thyroid gland. Deficiency of this hormone can cause weight gain and other symptoms like you are suffering, like fatigue, muscle weakness, irregular cycles, dry skin, and even in severe cases it can cause coma. So what we are going to do for you is to do for you faster blood test and imaging to your gland to confirm our diagnosis and to exclude the others. Then we'll give you another appointment to discuss the result. If confirmed, we are going to refer you to a gland doctor to give you the appropriate treatment in the form of replacement of this hormone. Um, is it curable condition, doctor? I'm sorry to tell you that it is controlled or controllable condition, but it is not curable. Most probably you are going to receive treatment forever, and this will be decided by the gland doctor himself, according to the investigation or the results of the investigations. This is a case sample of weight gain as an application of our skeleton today. It's very easy case to have the full mark history taking. If you put very good differential diagnosis in your mind and in your white paper before going, you can get the diagnosis so easily. Uh, most of the cases, there is most appropriate diagnosis and other differential diagnosis. But some cases can has differential diagnosis, not definitive diagnosis or most appropriate diagnosis. But you have to put your differential diagnosis in a pattern that correlate with the positive data with the patient. Don't put don't put a list of differential diagnoses like 7 or 8 or 9 differential diagnoses and to enumerate to the examiner that this patient may have uh, hypothyroidism or Cushing or polycystic ovary syndrome or insulinoma or chronic liver disease. No, it's not like that because the examiner will consider you a text doctor like that. You have to put your most appropriate diagnosis and differential diagnosis may be 2 or 3 only according to the positive data with the patient. Don't enumerate all the list of differential diagnosis that you put in your white paper before going to the station. Uh, thank you and see you in the next cases inshallah.